and welcome to Homeosynapse. This is Dr. Madhushree Datta, and today we are going to discuss portal vein in detail and also portal hypertension. So let us begin with portal vein. Portal vein is a very important vein in our body. It's a very large vein which collects blood from the abdominal part or the alimentary tract. That is, it collects blood from the gallbladder, from the pancreas, from the spleen, and it conveys that to the liver. This is what a portal vein does. Now let us start. As you can see in the diagram, the portal vein is collecting blood from all the parts and it's bringing to the liver. You can see in the black arrows, which is also showing a little bit of animation. Let us see the formation first. Formation of portal vein. Just if you can appreciate in the video here, it is formed by the union of superior mesenteric vein, this side superior mesenteric vein, and splenic vein. This is a splenic vein draining the blood from the spleen. So these two unite and forms the portal vein here, where behind the neck of the pancreas, at the level of second lumbar vertebra, that is L2. So this is how the formation of the portal vein takes place. It is about 8 centimeter long. It is formed by the union of superior mesenteric vein and the splenic vein, this way, at the behind the neck of the pancreas, In this diagram, just to help to understand or to ease it, we are showing it in front of the pancreas, but actually in the human body, it is present behind the neck of the pancreas at the level of second lumbar vertebra. Okay, this is the first part done, and now let us see the course. It runs upward, little bit to the right, first behind the neck of the pancreas, which we have already told, then behind the first part of the duodenum, and lastly to the free margin of the lesser omentum, this side. Let us see the next slide. Here we have the duodenum. Thus we can see this is the first part of the duodenum. Just above this we have the stomach. If you can just imagine, this is the first part of the duodenum. This is the second part and this is the third part of the duodenum. So the portal vein can be divided into 3 parts, as you can see. This part, with respect to duodenum, you have to understand the division that you have to understand with respect to duodenum. There is one part of the portal vein which is below the duodenum. If this is the duodenum, which is below the duodenum, this is infraduodenal part of the portal vein. This is the retroduodenal part. Retro means behind. So this part of the portal vein is behind the first part of the duodenum. So this is retroduodenal part. And this part which is above the duodenum, this is the supraduodenal part. So once again, the parts of the portal vein, it can be divided with respect to the duodenum which is present here. The one part where the red pointer is pointing out, which is just below the first part of the duodenum, that is the infraduodenal part. The part which is behind the duodenum itself, that is the retroduodenal part. And that part which is above the duodenum, that is the supraduodenal part. Coming to the termination, it terminates to end the right end of the porta hepatis by divided into right and left branches. You can see here how the right and left branches, these are entering. See, these are entering. So this way the portal vein is terminating. This way it's terminating. Okay. So now what we have to understand is that the relations of the portal vein. To study the relation, we have to divide it into infraduodenal part. That is, infraduodenal part means this part, right? So infraduodenal part means this part, which is below the duodenum. So you can see in the diagram itself what we have. We have the neck of the pancreas. Point number 1, we have the neck of the pancreas, and also we have the IVC draining from here like this. We also have the IVC which is draining from here like this. This is the IVC. This is the I, this is the V. Once inferior vena cava, IVC. VC is draining it, or it's just behind neck of the pancreas we have, and the IVC we have in the infraduodenal relation, in the infraduodenal relation of the portal vein. Now coming to the next part, that is retroduodenal, which is behind the duodenum. So anteriorly you have to understand the relations here in the retroduodenal part. Anteriorly you have the first part of the duodenum. Common bile duct is also coming here, and gastroduodenal artery is also coming here. Posteriorly, you have the inferior vena cava. So posteriorly, inferior vena cava will be there, and in the front of this, you have three objects, so three things. That is the first part of the duodenum, that is a common bile duct, and that is the gastroduodenal artery. And behind, you have this IVC again. You have this IVC again. Coming to the next part, that is supraduodenal part. That is above. That is the supraduodenal part. You can see in this was the supraduodenal part. This is having the hepatic artery, proper hepatic artery. This is having the bile duct. Obviously, bile duct will be there because it is also going to enter the porta hepatis, right? So it will also be there. And obviously hepatic portal vein will be there. All the three will enter the liver. Bile duct will also enter the liver. It is also a part of porta hepatis that we had studied in the previous session, right? So it will also enter the liver. Now coming to the posterior relation. In the posterior relation, we have the inferior vena cava, which is separated by the epicloic foramen. So now we are going to study the tributaries of portal vein, which is very important to understand for the exam point of view, because there may be several questions from this one aspect. Tributaries of the portal vein. As you can see in the diagram itself, the tributaries of portal vein. First, as it was formed by the superior mesenteric vein, so it will be a tributary, superior mesenteric vein, point number 1. Point number 2 is this splenic vein. This way forming the portal vein. So obviously this will be the tributary of portal vein. Next in the list we have the left gastric vein, which will be a tributary of portal vein. Then we have the right gastric vein, which is doing the anastomosis here, left and right gastric vein. So both of them will be a part of, the tributary of the portal vein. Right. Next in the list, we can see cystic vein. Cystic vein will also be a tributary of the portal vein. Then we have superior pancreatico-duodenal vein, which will also be a tributary of the portal vein, and also the para-umbilical vein, which is not shown in this diagram. Para-umbilical vein will also be a part of this part, this tributary. So once again, what are the tributaries of portal vein, guys? Point number 1, this one, you can see superior mesenteric vein, superior mesenteric one tributary of the portal vein. Splenic vein, this way draining the blood all the way from the spleen. This is also a tributary of portal vein. Then we have right gastric and the left gastric vein, which is doing anastomosis here. They are also draining into the portal vein, so they are also tributaries of portal vein. Then we have the cystic vein, which is again draining into the portal vein, which is also again a tributary of the portal vein. Then we have pancreatic or superior pancreaticoduodenal veins, which are draining all the way from the pancreas duodenum to the portal vein, which is also a tributary of the portal vein. Then we have para-umbilical veins, which is not shown there, which is also bringing the blood from the abdominal parts to the portal vein, which is also a tributary of the portal vein. Right. Now, let us see. This is the same diagram which is showing the tributaries of portal vein. It is showing in a more better way. It is even showing the things in a more better way, the relations and all, the diagrams and all, but this is the same, one and the same diagram. Now, let us start with another important part, that is the photosystemic communication or the portocaval anastomosis. We have studied all about portal vein till now. So, if there is portal vein, there will be some pressure in that. The normal pressure in the portal vein that we have is 5 to 15, that is 5 to 15 mmHg. 5 to 15 mmHg. But which is a characteristics of normal liver. In normal liver, this is the normal pressure. Suppose a patient who has developed cirrhosis of liver, this in this diagram which you can see, cirrhosis of liver where the pattern or the texture, the cells and all, the hepatocellular structure is completely destroyed. It's totally or is very much destroyed. In such patient, what will happen? In such patient, the pressure will rise. And in any condition where the pressure rises more than 40 mmHg, the patient will develop portal hypertension. Whenever the pressure will be more than 40 mmHg, whenever it will be more than 40 mmHg, the patient will develop portal hypertension. Not only cirrhosis of liver, there can be many other conditions like thrombosis of the portal vein. Actually, what happens, as we had seen in the diagram, portal vein was draining the blood all this way. Now, please look at the diagram and try to assimilate or try to appreciate, and then we can look back at the books. This is the portal vein which is draining the blood from the gastric region, from the spleen, from the gallbladder, etc., and draining it to the liver. Now, if there is some condition where the cells of the liver is destroyed, like cirrhosis, so it will not be able to drain properly. There will be backward flow of the blood from the liver. There will be backward flow, or if there is some type of thrombosis of the portal vein, then also it will lead to backward flow of the blood. So this will increase the pressure, and this pressure may increase to more than 40 mmHg. If it increases to more than 40 mmHg, we can see many clinical signs that we are going to study now, and that is what is mainly concerned with portal hypertension or portocaval anastomosis. Now you see, there are certain communications which are the important sites or the important sites of photosystemic communication. We are going to discuss that one by one. One among them is the lower end of the esophagus, like A. or the pointer, as the red pointer is moving, you can see this part, which is the A part, which is showing the lower end of the esophagus. It is also one of the important communication of the esophageal vein. And we have discussed the anastomosis and all in this condition previously when we were discussing the tributaries of the portal vein. Tributaries of the left gastric vein, that is portal anastomosis, the esophageal tributaries of the accessory hemiazygous vein, that is a systemic vein. This is the azygous vein. You can see in the diagram, this is the azygous vein, this is the esophageal vein, and the left gastric vein, it is doing the anastomosis here. If there will be backflow of blood from the liver due to liver pathology, due to thrombosis of the portal vein, whatever it is, that blood will flow back this way in this communication where there is an important anastomosis taking place. As a result, the blood will flow in the opposite direction, like the blood is supposed to drain from the gastric region, from the esophageal region into the liver. Due to some pathological condition, it is not occurring and the blood is moving in opposite direction this way, in this direction. So it will be coming out of the body, that is the patient will develop a condition that is known as hematemesis. Hematemesis means vomiting of blood, and this condition the patient develops esophageal varices. Esophageal varices. It's a very important clinical condition because the patient may develop a very deteriorate the general condition of the patient. This may deteriorate the general condition of the patient and the patient may die ultimately. This can be very, very fatal. It can be very, very dangerous. And it may cause the rupture of the esophageal vein also if the pressure increases too much. Actually, if the backflow of the blood is too much, then it can happen. So that is one condition where in portal hypertension, this can happen. The patient may develop esophageal varices due to the backflow of the blood into the portal vein, maybe due to some pathology in the liver like cirrhosis of liver, or due to thrombosis of the portal vein, point number 1. Point number 2 is that the patient may develop ascites, that is accumulation of fluid inside the stomach, abdomen. I'll show you the image, then you will understand what I mean to say actually. Okay. The second, this is I was discussing an important site of photosystemic communication. This is point number 1, which is an important part of the photosystemic communication. Second is the umbilicus. You can see in this diagram also, this is the umbilicus, and this one is the para-umbilical vein, which was I was talking in the previous slide, which was not there in that slide. It is there in this one, para-umbilical vein, which is also a tributary of the portal vein. Okay, now focusing on umbilicus now. Right, this is the second part. This is the second part. So the left branch of portal vein, anastomosis with the anterior abdominal wall. This is the left branch of portal vein. It is anastomosis with the anterior abdominal wall. So all the blood from the anterior abdomen in a normal condition like you and me, blood from the anterior abdominal wall from that region is going into the ultimately draining into the portal vein, which is again draining into the liver ultimately. But in a patient where there is portal hypertension, cirrhosis of liver, or there is some kind of thrombosis of the portal vein, etc., there will be again backflow of the liver, backflow of the blood in the liver region, from the liver region into the portal vein. In this one I already showed. So in the previous one, the blood was going to this part, in the esophageal part, where there was one anastomosis, one communication. Now, the same blood which was coming in the backflow can also come to the umbilicus region. It can also come back to the umbilical region and it can come here as a backflow because it is also a communication, right, where there is anastomosis of many arteries. This will lead to a condition which is known as capote medusa. That is, the distension of the abdominal vein. This is the umbilicus, and there will be distension of the umbilical veins. There will be distension of the umbilical veins. We all have studied about Medusa, right? She was a very beautiful lady. Instead of hair, she had snakes all over her head, and anyone who would look into her eyes would turn into a statue or something like that. So this we had read. So the resemblance, or why it is called as capod medusa, is the reason is that you see around the umbilicus the veins dilate and they become like this, which is resembling the hair or the snakes of the medusa. This is Medusa's hair, or the like which was there on her head, snakes or hair, whatever there, it's resembling like this. So the name is given Capod Medusa, which is nothing but the distension of these paraumbilical veins. Okay, so when we are coming to the medical aspects, we have to understand that it is nothing like that. There is no snake or no something like that. These are the dilatation of the veins in the umbilicus, which is due to the backflow of blood from the liver in case of portal hypertension. So this is what is meant by caput medusa. Now for a clinician, caput medusa has got a huge diagnostic value to diagnose the case, to confirm that it is a case of portal hypertension. The patient has developed portal hypertension along with other clinical histories, other clinical symptoms. Can be correlated this way. This is point number 2 of the communication. Point number 3 is the one which is marked in B, the anus. Now in the anus, you can see with the superior rectal vein, you can see this one, superior rectal vein, anastomosis with the middle and the inferior rectal vein, middle and the inferior rectal vein. So again, this is also another important site of the anastomosis or the site of a communication. So if there will be portal hypertension, there will be backflow of liver blood from the liver. So far we have seen this blood was draining first or in the esophagus and causing esophageal varices. Ultimately, there was vomiting of blood from the mouth. There was vomiting of blood from the mouth of the patient, which is known as hematemesis. Secondly, we have seen there was caput medusa, which means dilatation of the paraumbilical vein, which is due to the portal hypertension. Point number 3, now what we are going to see, hemorrhoids. Hemorrhoids in the anal canal, which is responsible for repeated bleeding, from the anus. And why do they develop? It is again because of the backflow of blood in this way. In this way it is coming down, and again due to the increase in the portal system, in the portal vein, this will cause due to portal hypertension, this will cause bleeding, hemorrhoids here. Again, this is an important point to note. So point number 1 was esophageal varices that the patient will have in portal hypertension. Point number 2 was caput medusa, that is due to distension of the paraumbilical vein. Point number 3 is this, around the anus, where there was anastomosis of superior rectal vein with inferior plus middle rectal vein. Inferior plus middle rectal vein. There also the patient will have hemorrhoids which will be bleeding violently. Point number is the bare area of the liver, which is not typically shown in this diagram, but there also hepatic venules, anastomosis with the splenic and the intercostal veins. There is also one anastomosis in the bare area where there is anastomosis of the phrenic and the intracostal vein. Next, you have the posterior abdominal wall. That is a vein of the retroperitoneal organs. Like you have duodenum, which was there, like the ascending colon, which was there, like the descending colon, which was there, which is there in the diagram D. In this, we have in the diagram D. See, retroperitoneal vein. See, this is the retroperitoneal vein. This is from the colon, right? So in this condition also, the patient will develop problem because the retroperitoneal veins of the abdomen and the renal capsule also, they also anastomose like there. The splenic vein anastomosis with the renal and the azygous vein also. So this part is also you have to understand, and that is why the patient will develop complications here also in the posterior abdominal wall also. Now come to the liver. Rarely the ductus venosus remains patent and connects to the left branch of portal vein directly to the inferior vena cava, but it is a rare condition because we have all studies that ductus venosus actually degenerates. So it's a very, very rare condition that it remains patent. So that is the end of it. Thanks for watching. If you like the video, please do like and share.